This is Gene Krebs.
Hi there. Oh. Whoop. Whoosh.
And we're high on Ohio.
Hi, I'm Tara Delansky, filling in for my colleague Gene Krebs with the Center for Community Solutions, and we are here interviewing Dr. Otis Brawley, who is the Chief Medical Officer of the American Cancer Society, and he is here in Columbus with me today, and I just want to welcome him here and thank him very much for visiting us here in our fine city, even though you came from Michigan originally.
Thanks for
Throw
having
that
me.
in there.
It's wonderful to be here.
Well, and we really are thrilled that you're here speaking with us. And I will start with something easy. So if you could tell us a little bit about your background, where you came from originally, and how you started, and how you got to where you are today.
Well, I grew up in Detroit. I went to the University of Chicago. I trained as a physician, and actually I have some Ohio connections as well. I was a resident at Case Western Reserve University in Cleveland for a while, trained in internal medicine there. Then I went and did a medical oncology fellowship at the National Cancer Institute and stayed on at the National Cancer Institute for some time in a faculty position, moved on to an academic position at Emory University, and about 7 years ago I became Chief Medical Officer of the American Cancer Society. I'm still a professor at Emory University, but I spend most of my day and most of my time working on issues for the American Cancer Society.
Okay, well that's great, and you've sort of been all over. And can you tell us a little bit about? And I've heard you speak earlier today. And can you tell us a little bit about where you grew up and how that may have influenced sort of where you got to today?
Yeah, I grew up in the inner city of Detroit. I was fortunate enough to go to some Catholic schools and be influenced by a number of Jesuit priests who taught me a number of important things about how to think. And I frequently try to impress upon my students today that they need to think about what it is we know scientifically in medicine, what we don't know, and what it is we believe. And I also try to impress upon folks what Father Polakowski used to tell me. Doctors have a problem frequently in that they confuse what they know with what they believe.
So, and I think that advice has really shaped, at least it seems to me, shaped the book that you wrote, How We Do Harm. Yeah. And if you could talk a little bit about that book that you wrote. And I know I'm missing part of the title there, too.
No, How We Do Harm is the title of the book. And what we do is we go through a number of things in medicine, and we talk about what is known about that procedure, or about that treatment, or about that disease, what is not known, and what is believed. And we talk about how rational treatment very frequently would be different from what we in the United States are doing in that disease. Rational treatment being practicing what it is we know. And I give a number of examples of things that we have believed in medicine, believed to the extent that we thought we knew it, and ultimately a few people, sometimes people who are highly criticized for questioning it, ultimately were proven to be right. And what we believed was actually wrong and was actually inappropriate. And in some instances, in the case of the Halsted mastectomy, for perhaps 40 or 50 years, we were harming people because we failed to really truly be scientific, we failed to be skeptical, and we failed to question what we were doing.
And how does that influence your training of, or physicians in training now? So how is that something that you work into how you teach them?
Well, you know, physicians in training today, medical students, young physicians, they actually get a lot more mathematics, a lot more statistics, and a lot more public health training than mid-career physicians like myself. And so many of them are much more open to the kinds of things that I'm talking about than mid-career physicians. I actually look at the young generation of physicians today, and I'm just amazed, not only at the opportunities they have to actually truly affect disease, but their understanding of how you think. In many respects, my book's been very popular with them because I'm preaching to the choir.
That's interesting. And you mentioned public health. So we have a long history in our organization of being involved in public health and public health policy issues. And what do you see as the public's role in prevention? And I know earlier you mentioned you're an epidemiologist too, so I wonder how that shapes your thoughts on this.
Yeah, it's my belief that some of the major problems in medicine are not going to change until doctors and patients are starting to be interested in changing them, into bringing a little bit more rationality to the practice of medicine, especially focusing more on prevention of disease. Our current healthcare system is overwhelmingly geared toward screening and diagnosis and labeling people with a disease that can be treated, when I think our healthcare system needs to be much more of a European or Canadian model, where the doctors are actually focused on how do I keep this person healthy.
So this is, for the policy wonks, this is sort of the upstream approach in public health, is that we're seeing people long before they're sick.
That's right. The upstream approach in public health is prevention of disease, the encouraging of healthy habits. I think we can do a great deal more to teach kids in 2nd and 3rd grade how they should be eating, as opposed to not focusing on those sorts of things and then having an obese cadre of high schoolers.
Very interesting. So you mentioned sort of the responsibility of the doctor and the patient, and knowing these things that can keep them healthy rather than sort of doing this downstream approach. And I'm wondering what your take is, and I've actually seen a lot in the media lately about this sort of doctor-patient role and how they work together. And I think a lot of times people have trouble questioning a doctor even if they are suspicious of something that's not maybe quite right.
Yeah, a couple of issues. One of the great problems right now is that a doctor or healthcare provider very frequently only has 6 to 8 minutes with a patient in an encounter, and that's really unfortunate. We also are having a smaller number of doctors going into primary care, increasing numbers of physician's assistants and nurse practitioners. That's actually a good thing. My experience is that nurse practitioners and physician's assistants have a little bit more time and are much more willing to have these discussions that I think need to be happening. Rather than just writing someone a prescription and walking out, we actually need to be much more in the life coaching business. This is how we stress prevention of disease. This is how we're going to actually keep people from consuming lots of health care. I'm very concerned that our current healthcare system is so overburdened with diagnosing and treating and charging for that treating that it's actually going to ruin the economy. That's one issue, but it's not helping the patients either.
So we'll go down that road now. How this the impact of our current healthcare system, what that impact is on the economy, and I know that that's something you spent a little bit of time talking about.
In 2010, the United States spent about $8,400 per man, woman, and child on health care. That was our health care costs. It's about 19% of the gross domestic product. That's an awful lot. The second and third most expensive countries in the world for health care spent about $4,400 per man, woman, and child. So we're terribly outspending for health care. Our outcomes are not as good as many of the other countries of the world. Indeed, when we look at things like life expectancy, we're 49th. Among countries in the world, when we look at infant mortality, when we look at even white male life expectancy, we don't do very well. When we look at mortality rates for a number of different cancers, my field, we don't do very well. When we look at mortality rates in cardiovascular disease, we don't do well. Yet we spend an awful lot of money on health care. Some people actually think we have the best healthcare system in the world. Truth be told, if you're wise enough to know how to use it, it probably is the best healthcare system in the world. But overwhelmingly, 90+% of us are not wise enough to know how to use it. And so I'm very concerned that our outrageous healthcare costs and the growth that's projected over the next 20 years is going to entirely ruin our economy, perhaps bankrupt the United States because of the increasing costs of healthcare. And as I've already said, we're paying a lot for health care and not getting very much out of it in terms of quality.
And you mentioned, basically, we would need to focus on practicing rational medicine. What we're doing right now, there's a lot of irrational thought going into that.
I like that word. The politicians like to scare people by talking about rationing of medicine without ever mentioning the fact that a lot that's going on right now is irrational, and what we actually need is rational use of medicine. There are many treatments that are unnecessary, actually even harmful. That's where the title of the book came from. That are going on, and these irrational treatments continue because people can make money off of them, or people don't realize the lack of science behind them. We need to be rational about our use of our resources. There are some treatments that are just so expensive, we best not use them, and it's actually cheaper to prevent the situations that might cause them to be needed to be used.
And so I'm going to ask full disclosure, I wrote my thesis in grad school on healthcare spending in the last year of life, and sort of looking at policies around advanced directives and sort of lots of things that people spend a lot of time, I think, in their life not wanting to talk about, but then they sort of get to these last years or months in their life, and a lot of spending in healthcare happens during that last year, but ultimately this person is dying within this year, and it's not curing them. So I'm wondering what, especially in terms of this practicing more rational medicine, how hospice and palliative care, end-of-life care can play into that.
Well, now, the palliative care movement has blossomed in the United States over the last decade or so. It's actually a board-certified specialty. And palliative care should be applied to people in all phases of treatment, even people who are being treated for a broken leg or appendicitis. Things that are eminently treatable and curable sometimes need to have palliative care, where we look at quality of life, we look at pain control and other things. People who have ongoing chronic diseases like HIV or coronary artery disease ought to have palliative care. I mention that because some people think of palliative care as only end-of-life care or hospice care. So we need palliative care and hospice care for people who are at the end of life as well. I am sometimes very forgiving that people don't realize that an individual is at end of life, and then they die and you realize how much money you spent in the last 6 or 9 months. But there is a group of people who are clearly dying, clearly entering the twilight of their life, who really we need to think about, does this individual need comfort measures where we focus on keeping them out of pain, keeping them feeling comfortable and good, surrounding them with their loved ones? Or do we need to be interventional and try to keep their hearts beating and keeping them breathing? And I've had time after time incidents with families where we actually advise comfort measures and the families are not willing to let go, sometimes because they feel guilty about how they treated the person in life, sometimes because they're just unable to accept the fact the individual is dying. And I've even had conversations with families where I ask if we can just do everything reasonable, and they say everything is reasonable. And we end up with patients who are, for 3-4 months at a time, on a ventilator, unconscious, with all kinds of various medical interventions that's really aimed at keeping their heart beating and keeping their lungs breathing. It's not aimed at keeping them alive.
Mm-hmm. Well, and I think that is something that is difficult for a lot of people to deal with, but something that needs to be talked about before you're in that last couple months.
You know, it's regional. It's regional. People in the big cities have much greater difficulty dealing with these issues and making these decisions to let someone just be kept comfortable than people in rural areas. Perhaps people who are from farming communities or more rural areas are much more able to understand that death is a part of life. Whereas people in big cities, especially people in the Northeast and West Coast, every death is somebody's fault.
Interesting. So you mentioned that some people consume too much healthcare and others are consuming too little, and that sort of a lot of the problems can be sort of dwindled down to those two issues. And just to bring this back to sort of current events, we've recently, within the last 6 months, expanded Medicaid in Ohio under the Affordable Care Act. And I don't want to get too far into any of the politics surrounding the Affordable Care Act, but I think that we've really championed the Medicaid expansion in the state, looking at probably people in their lives who have maybe consumed too little health care. And this is the first chance a lot of people have at having coverage for health care. And I'm wondering, maybe talk to us a little bit about the consuming too much health care versus consuming too little, and then maybe how the Affordable Care Act, Medicaid expansion in particular, might have an impact on that.
Sure. There are some very wealthy people, middle-class people, insured middle class, who have to get every test, not realizing that we live in a world where 1% of all cancers today are caused by medical radiation from people who are getting too many of these tests. We have people who have to have all of these pills when, quite honestly, they don't need much medicine at all, and taking all these pills can hurt you. They just consume, and they think the more they get and the more they consume, the better off they are. And they don't realize that there are harms associated with the consumption of medicine. Then you have people who have no access. And I even have written papers about how 7% of black women and 2% of white women in metropolitan Atlanta who are diagnosed with a low-stage breast cancer get no treatment beyond the diagnosis of the disease.
At the point where it could be curable.
At the point where it could be curable, they get no treatment. So we have these two things juxtaposed about each other. Many people who get no treatment have no access to care, no way to pay for it. I will tell you that giving them Medicaid, while helpful, is not the only solution. They're going to need help or guidance from someone to help them go through the system, to navigate them through the system, and how to consume the health care and how to wisely use the health care that they now have available. I am actually also worried that in states that have not expanded Medicare, we're going to create a new subclass of Americans who are very poor, disenfranchised, and without health care. Now, having said all of that, I will tell you, while I support the Affordable Care Act, it's my feeling that the Affordable Care Act didn't go far enough. It is better than the old system, but it is not good enough, and we're going to need to tweak it and change it over the next several years so that we can actually save more lives. And people who are against the Affordable Care Act, I have nothing against anyone who is against the Affordable Care Act who proposes some system that would help us take care of this problem of millions of Americans who have a lack of health care. In my mind, it's okay to be against the Affordable Care Act if you're proposing some solution to this problem. But it's not okay to be against the Affordable Care Act if you're just ignoring the fact that there are people out there suffering and dying because they don't have health care.
Very interesting. So I will, I guess, leading into this question, we'll steal Gene Krebs. I think he uses a magic wand. But if you could wave a magic wand and make one, policy change, change to how people approach their health, maybe you can have 2 wishes. I'll give you 2. Gene doesn't do that, but I'll give you 2 wishes.
Can I have 3?
That's a genie, so yeah, sure, we'll go with that too.
The things that I wish we could do to change our healthcare system was, number 1, I would make sure that everyone had access this system, even the Affordable Care Act, is not universal access. We'll leave open the question of one payer versus a multi-payer system, but universal access. Second, I would change the system such that our medical system were not a system that spent so much time finding and diagnosing and treating disease, but spent a lot more time in trying to prevent disease through education, trying to keep people from getting sick. I cannot overstress the difference between European healthcare and American healthcare. Is American healthcare tries to identify people as being ill so they can be treated, and European healthcare spends a lot of time trying to prevent people from getting ill. And ultimately, when you look at the prevention in the European healthcare systems, their long-term outcomes ironically turn out to be much better than in the United States. So, universal access with a transformation toward prevention. Those are my two. Okay. If you gave me a third, I would actually put some navigation and education into the system where people were educated about healthful habits, be it diet and exercise and not smoking, as well as people were educated about how to go through the medical system.
Do you see that happening in the school, primary and secondary education, or just through your family doctor, or how would that?
I would love to see the schools get involved in this. You know, I guess if I were able to do one thing to improve the lot of healthcare in the United States, I would improve the education system in the United States. If we had more people who are able to read and write, more people who understood about healthful habits and so forth. Now, I've got great data when I do these epi studies that people who have a college education have a much better life in terms of health care than people who have a high school education, who have a much better life than people who have just an 8th grade education. There's something about education that prevents disease.
And that's that interplay with all the systems that we can't see ourselves in silos. We have to evolve.
I can do these complex calculations for you and come out with numbers about how many million Americans would not die every year if all Americans had the death rate of college-educated Americans.
Wow.
It actually is millions of lives saved, not just from cancer, but heart disease, diabetes, and other things. We would prolong people's lives if we simply were able to give everyone the death rate of college-educated Americans.
Well, I want to thank you very much for visiting us and taking the time to do this interview. It's really fascinating and lots of stuff that we can all can learn from you and take it further, hopefully, and actually make some changes.
Thank you. It's wonderful to be here.
Thank you.
For more about the Center for Community Solutions or their publications, please visit www.communitysolutions.com.